I just want to welcome everyone to the KCQVIC Forum. We're very excited about the agenda that we have set up today. Today's topic is radical changes in healthcare delivery due to COVID-19, what we did and how it worked. And it's an extremely important issue that really has dramatically impacted healthcare. So we're really excited to hear from all of our different stakeholders. If you have not been to a KCQVIC forum before, or even if you have, as a friendly reminder, we started these just over 2 years ago in May of 2018, and this is actually our 19th forum today. And we like to feature, brief talks. You can see these are all approximately 15 minutes per speaker, and just kind of brief talks by different stakeholders and their perspective, because everyone brings a different lens to the topic, and it's really important that we all learn from each other as we learn how to collaborate and solve these problems for our region. So, today I'm just going to share a couple quick slides before I turn it over to our first speaker. So letting everyone know a little bit about the KCQVIC. So the QVIC is the Kansas City Quality and Value Innovation Consortium. And our vision is really to bring multiple stakeholders together to improve the quality and value of healthcare. We're really aiming to do regional collaboration to improve quality of care, patient outcomes, and reduce costs of care, which are constantly rising. And we're, especially as we move to a value-based payment system, these become more pressing. And when hospital and healthcare systems are pressed to their limits currently, it's important that we think more creatively. And so, myself, I'm a health services researcher by training. I'm a research assistant professor at the University of Missouri, Kansas City, and I'm one of the key facilitators of the QVIC. And the other two individuals whom I work with and are the other facilitators of the QVIC are Dr. Carol Decker, who's a nurse PhD researcher in quality improvement and outcomes, and Dr. John Spertus, who is a nationally recognized leader in patient outcomes. And we're supported through our partners, and which, we are part of the KU Frontiers Clinical and Translational Science Institute. We also have affiliations with the University of Missouri, Kansas City, as well as with BioNexus KC. So a little bit more about our consortium members. People involved in the consortium, are hospital systems, healthcare providers, researchers, purchasers, patients, community-based organizations. So really anyone and everyone that touches health, which is all of us. And so we're all working together to solve these common problems. And so this is just this little word cloud of just some of the regional priorities that we've uncovered through our kind of strategic priority needs assessment of the entire community and everything that was important to all of the stakeholders to improve upon. And so, through a process that I'm not going to talk through here, not the right venue to get into all the details nor time, but through a process, we narrowed this down to two different topics to start out with for two different projects that we wanted to implement, and then also evaluate the outcomes of two different quality improvement projects across multiple hospitals. So we're getting multiple hospitals, community-based organizations, providers, all to kind of play together on two different projects. And we settled on opioid management, and particularly we're working with the KC EPIC, which is Engaging Patients in Care Coordination Program, which is an ED-based model of care that connects individuals with opioid use disorder to peer recovery coaches into community treatment. And those are in approximately 9 different Missouri side hospitals. Right now we're working with the Missouri Hospital Association. And then our other project is Transitions of Care for Heart Failure. And this one is more of a suite of tools or interventions that are used to support kind of the carousel of heart failure. So where we have different aspects that we can help with the different stakeholders in terms of admission, transitions home, to living with chronic heart failure, to exacerbations back to the ED. And so we're working, we have research teams and quality improvement professionals working with these teams and hospitals to implement and evaluate these projects. And if you are someone who's interested in these projects but not yet involved with us, and maybe are getting ready to turn back to a little bit of quality improvement that's not related to COVID, please do visit our website. You can fill out a form there to stay in our listserv, or to join us, as well as, you're welcome to email me directly with any questions you have, or letting us know that you're ready to join us. So briefly, we're already over time myself. So this is our 2020 forum schedule. As you can see, we are on today with radical changes in healthcare delivery, just letting you know our schedule for the year. And with that, I would like to turn it over to our first speaker, who is Dr. Mario Castro. He is the Chief of Pulmonary Critical Care and Sleep Medicine and Vice Chair for Clinical and Translational Research. Also the new Director for the Frontiers Clinical and Translational Science Institute, and Director of the Rainbow Clinical Trials Science Unit at the University of Kansas School of Medicine. So we are very delighted to have Dr. Castro speak from a healthcare inpatient perspective on implementing a regional critical care response to the COVID-19 pandemic. So the floor is yours, Dr. Castro.
Thank you. Says you cannot start screen share with the other participant in sharing. All right, well, thank you, Dr. Farr, and thank you for allowing me to be part of this QVIC forum, and I'm excited because I have not been part of it before. I am a Kansas City boy, though, and at least some of those partners I've been part of before I graduated from UMKC, and I've been here now at KU for about 8 months. So, well, lo and behold, as I took a new job here at KU, then COVID came around the corner, and quickly had to think about how we would encounter this pandemic as we all kind of were thinking about this. As you think back early in March and late February, how do we plan for this? There was a Saturday morning, one of my colleagues had emailed me an interview that was given by an intensivist in Italy that was in the midst of the pandemic, and showed me, these graphs of their exponential growth of cases that were hitting their ICU. And I said to my colleagues at that point, I said, well, I think we need to get something prepared here in Kansas City, because if this hits us, we're not ready. And so I just wanted to share with you what I think has been a very rewarding collaboration across these medical centers in our region to really meet together. We were meeting on a weekly basis, initially sharing stories about how we were encountering the pandemic. As you know, Tier, this is across multiple health systems and across state lines. So this was unprecedented. A lot of these colleagues knew each other professionally, but had not really been engaged in a conversation across these health systems. And it's still a challenge, as we'll talk about at the end. So when we were thinking about the response to COVID, and based a little bit on the information that came out of China, we met with leaders from Guangzhou, and we met with leaders from Italy. And we quickly came up with some of key questions. What happens when we exceed our level of staffing? What happens when our capacity is exceeded for our hospital in our region? How do we create a model where critically ill patients have appropriate access to care with COVID infection? As we know, that access to care is very important, and in regions around the world where that access to care was impaired, how do we do a better job preparing for that? And then we were also concerned, with a COVID surge, how would that affect our non-COVID patients that needed critical care access, and also how do we protect them appropriately to avoid cross-contamination? What would be our true capacity in a surge epidemic pandemic here in our region? We didn't have that information. And then lastly, should we start some kind of regional coordinating center that will give us some real-time COVID-19 information for the region? Having really not an existing infrastructure for that, there have been some hints of that EM resources, an example of that, but not really consistently collecting information. So, Dr. Farr, can you hear me still, or are we frozen? Oh.
I can still hear you.
Okay.
I can hear you.
Yeah, but my slides are frozen for some reason.
Are you clicked on the slides and not the Zoom app?
It's in presentation mode and it's frozen on me. So, is there a way you could take over, Stacy, or not?
Maybe try to stop sharing and then reshare, maybe.
Yeah.
Well, yeah, I can't even see a mouse. That's a bad sign. Let's see. Yeah, I'm afraid I have to almost restart the computer, which will cut off the connection.
Try hitting escape. Maybe that'll get you out of the.
Yeah, no, I've hit it about 20 times already.
Like,
Daisy, do you have the slides that you might be able to take over sharing?
Yeah, I don't have the slides. So I wonder, we could pause, let Mario reboot and move on to the next and come back to him at the end or after the next.
I'm dying to hear how this story evolves. So
I know, now that we're
I
ready.
hope you can get on quickly again, Mario.
Okay. Yeah, I'm working on with my other computer, but I'm hoping to log in with my laptop and then
Switch it over.
Yeah.
Is Dr. Sperry here, or should we go on to Michelle Weininger?
That's what I was thinking. Go to the other healthcare perspective and then jump back. Is Brett on, Dr. Sperry?
This is Shaylee. I'm trying to stop sharing his screen, but it's not letting me. So I think as the host, I can override and share my own screen, which would, I think, kick him off. So I'm going to try sharing my screen to maybe clear it out a little bit. We've never had this issue, but we'll figure it out.
Yeah, I'm logging on with my laptop, so.
Oh, did you see my screen and then it went away?
No, I don't think it did. Okay. Is Dr. Sperry on? If not, maybe we should, while we're waiting, should we jump to Michelle then? I think that might be a good, in the interest of time, since we're so full. So if that's okay, we'll come back to the rest of Dr. Castro's talk right after we hear from Michelle. So I think what we'll do is we'll jump to our payer perspective, which is telehealth before, during, and after the COVID-19 public health emergency. And so we have the privilege of having Michelle Weininger, who's the Rural Health Coordinator and Local Engagement and of the Local Engagement and Administration team with the Centers for Medicare and Medicaid Services in the Kansas City office here. So Michelle, if you would like to, if you can, take over.
Sure, and I don't have any slides, so we're good.
Oh, perfect, even better.
You guys can play with that, and I'll just talk.
Okay.
So really, CMS has had a handle and had a hand in a lot of things related to COVID. So trying to pick a subject we could talk about we had a lot of choices, but we decided to focus on telehealth today. And so again, I want to talk about what telehealth looked like from a CMS perspective before COVID, what it looks like right now, and then talk about maybe what it's going to look like afterwards. So basically, before the public health emergency, Medicare did pay for telehealth visits. We paid also for virtual check-ins and e-visits. And we would pay for telehealth visits on a limited basis. If the person had to live in a designated rural area and they had to leave their home and go to a clinic or a hospital or other type of medical facility, which we called an originating site. So wherever the patient is, that's the originating site. They had to go to that location for the service. And the patient's home was not an appropriate, could not act as an originating site. So, and then you had the distant site practitioner, and that's the provider who was furnishing and could bill for payment for those covered services. So originating site's patient, distant site is the provider who's providing the medical care. Similar to the originating site, appropriate practitioners were limited. So it was only for physicians, NPs, PAs, certified nurse midwives, CRNAs, clinical social workers, clinical psychologists, and registered dietitians were the only ones able to provide those type of services from a distant site. Services were also restricted to specific procedure codes, and some of those codes had time limitations. We really didn't have a vast amount of covered services. We covered quite a bit, but not a huge array of services. But we have been adding consistently over the last few years. For example, in 2020, we just started covering 3 codes that were for bundled services for episodes of care for treatment of opioid use disorders. So that allows the patients to be able to receive those services in their home. Starting with in early March, when the public health emergency was declared, Medicare, CMS rapidly started looking at how we needed to make sure that patients could continue getting the care that they needed. So now we pay for the office visits. We will also pay for other visits, hospital care. We pay now for across the country, regardless of the setting. So payments can be made for the expanded telehealth services. So we've expanded flexibilities for telephone assessment and management and E&M, or evaluation and management services. Also, some of the telehealth services are subject to Medicare coinsurance and deductible amounts. And HHS, the Office of the Inspector General, has actually given flexibility for healthcare providers to be able to waive or reduce those cost sharing amounts for patients who are utilizing telehealth services. As providers, most providers know that they can't, they're not allowed to waive the cost sharing or the deductible portion for a Medicare patient. And so this gives them the flexibility to be able to do that. Also, for the duration of the public health emergency, we are waiving the limitations on the type of clinicians who are eligible to furnish those E&M visits by allowing physical therapists, occupational therapists, and speech language pathologists to furnish those services. And there's a set of G codes that they're able to use to do that. We've also activated 3 CPT codes to describe the A&M, or assessment and management, or evaluation and management services conducted over the telephone. We are allowing hospitals to bill for services furnished remotely to outpatients by hospital-based practitioners in what we're calling temporary expansion locations. I've probably seen those on the news. There can be parking lot tents, hotels, even the patient's home can act as a temporary expansion location if it's designated to be so as a part of the hospital. In a final, or an interim final rule that we published about 3 weeks ago, we actually gave instructions to hospitals how they could go about designating and requesting that certain locations be temporary expansion locations. And the types of services that can be performed at those locations include wound care, drug administration, and behavioral health services. In regards to the originating site requirements, I mentioned previously that the patient's home could not be an originating site. For the duration of the public health emergency, we have deemed that a patient's home can be originating site. We want patients, if they're COVID positive, to not be going to the doctor's office. We still want them to receive care. They can do that safely from their home and stay quarantined. But we also don't want healthy patients going into a possible location that may have been where there may be a COVID exposure. It puts them at risk. So we expanded the ability for patients to be able to do that. And with the passage of the CARES Act on March 27th, we actually are allowing rural health clinics and federally qualified health centers to be able to seek reimbursement as distant site practitioners. Previous to the public health emergency, they could not be a distant site location. And that's really important for those people who, especially in the rural areas where that was their sole way of getting care. They weren't going to stop seeing those providers, but now the providers can be reimbursed for those services. So that was really important on that end. Telehealth services can, during the public health emergency, can be provided to patients in other states as long as the state goes along with the licensing. That's different now for the public health emergency. And for providers who are practicing out of their homes or providing care out of their homes, we are allowing them the flexibility to be able, they don't have to enroll their homes as their location. They can actually submit their claims using their office address that's currently on file with CMS on those claims. They don't have to go through another enrollment process, trying to eliminate that barrier. We've also implemented a provision that allows us to add new services to the list of payable telehealth services through what we call sub-regulatory guidance instead of having to go through the rulemaking process. And this has enabled us to be able to expand those services very quickly. It accelerates our consideration of those procedures. And this is great because we're getting feedback from providers, hey, this is working, or hey, we need this code to be covered. We're able to look at that very quickly and add it as if necessary. We do maintain a list of the codes that are currently covered. If you go to the cms.gov or gov website, just do a search for list of telehealth services and you can pull down an Excel spreadsheet or pull down a complete list of all the telehealth service codes that are covered, especially during the public health emergency. I want to talk very briefly about the 4 areas of telehealth and kind of where the nuances are with under the public health emergency. Prior to the PHE, we required telehealth services to go through an audio and video capable device. We are waiving the video requirement for certain counseling and behavioral health services and for those telephone E&M services. And because these services are considered the same as and paid at the same rate as an in-person visit, they are subject to the Medicare 20% coinsurance and the deductible amount. Prior to the PHE, the average, the reimbursement rate for an E&M service was between $14 and $41. Because we're paying at that in-person rate, it's now averaging between $46 to $110. The next area that we cover is virtual check-ins, which we began covering in 2019. Those previously were only available to established check-in or to established patients. They can now be provided to new and established patients when the service does not relate to a visit that occurred in the previous 7 days or occurs within 24 hours or at the next available appointment. So it's now for new and established patients. The key to this is that the patient must proactively initiate the conversation, but providers do have the ability to reach out to their patient population or to the population in general and educate them about that service being available. E-visits is the third one, and we began covering those in 2019, and those are non-face-to-face patient initiated, again, communications that occur through an online patient portal. Practitioners or providers who can traditionally bill Medicare for those E&M services or who could bill independently for E&M services can bill for the e-visits. Under the waiver flexibilities under the public health emergency, this is where those clinicians who normally couldn't bill independently for E&M services, like your physical therapist, your occupational therapist, your speech language pathologist, and your clinical psychologist, that's where they can now provide these type of e-visits and be able to bill and be reimbursed for them. And then something new, and we talked about this just a minute ago, is that we are now covering and reimbursing for audio-only E&M services. And this can be used when a patient does not have access to or they choose not to use that two-way audio-video technology. There are no location restrictions, so it's not rural-based or anything like that. And it's very similar to the e-visits. Clinicians who or providers who could independently bill those E&M services can continue to bill those using audio only. And the clinicians who prior to this who could not bill that E&M can bill for the audio only E&M. What's really important here for providers to note is they still need to document this because we are reimbursing this at an in-person visit rate. They do need to document that just like they would if the patient was standing in front of them, but notate in their document that it is a telehealth visit. So just moving on to what COVID is going to, what telehealth is going to look like from a CMS perspective post-COVID. Nobody knows what that's going to look like yet, but I can tell you we are soliciting feedback from our stakeholders, from the provider community, from beneficiaries. We're asking questions like what is working, what's not working, what's missing that you'd like to be seen or you'd like to have seen in the program, what changes would you make? You know, the best decisions that we can make, we can't make them in a vacuum, so we need this feedback. We want to make sure that we're making decisions with a lot of good information. So I strongly recommend you reach out to our office. We're happy to take comments, hear feedback, answer questions. We'll probably be doing some listening sessions around this. I know I meet weekly with the hospital and medical associations here in our region to get feedback from them. The last thing I really want to talk about are some of the resources that are out there from a CMS standpoint regarding telehealth, and that would be the telehealth.hhs.gov site. Great resource for providers and patients. CMS has a COVID-19 toolkit. Go to cms.gov, put in coronavirus toolkit, and you can find it. Good for patients if you're dealing with special populations. You know, it's just a great opportunity to learn what's going on. Plus, you can find out we have weekly stakeholder calls. You can get the call-in information from that and attend those. And then finally, I want to talk about the CMS Office of Minority Health website for additional COVID-19 resources. Again, cms.gov, put in Office of Minority Health, their page will come up. Their resources are available for those people dealing with vulnerable populations like older adults, racial and ethnic minorities, and people with disabilities. But the nice thing is they also have resources available in other languages, and they also have videos in American Sign Language. So if you're dealing with those kind of populations, great resources out there. I know we're doing questions at the end, so I'm going to turn it back over to you, Stacy, and thank you very much for inviting me.
Well done. That was so much wonderful information that you covered so succinctly and briefly. Thank you. So kind of letting everyone know we had some technical difficulties. I think if it's okay, Dr. Castro, we'll go back to your presentation where you left off, and then we'll go to Dr. Sperry after that. And so at about 3:40-ish, so about another 12 minutes, if that's okay.
Yeah, that would be fine.
Okay, great. Oh, I think you're on mute still, Dr. Castro. There we go.
Okay. Oh, did you want me to go ahead? I'm sorry.
Oh, yeah. You go ahead now until 3:40.
Okay. I'm sorry.
Sorry, I wasn't clear.
Are you going to be speaking to the group now?
Sorry, my computer crashed and I actually had to get IT on board.
Would it be easier if we turned to Dr. Sperry's while we wait for that? Oh, I see you.
Can you see my screen now?
Yep, we can.
Okay, great. I found that IT is very challenging here at KU. That's funny. As I was talking about, we were trying to think through what would be an appropriate response in the setting of the pandemic here for critical care for here in Kansas City. And through our critical care directors, we came up with some points that we could all agree to that would help us. And so one, we wanted to establish a central coordinating center. In essence, that was centralized here at KU with a REDCap database where we captured information. We wanted to, as in all public health, do an assessment first and assess really what our existing capacity is, which we didn't have that information, surprisingly, as well as our surge capacity would be. And then we wanted to obtain kind of the key contacts. So if somebody was having a problem in one of our regional hospitals and exceeding their capacity, they could quickly divert cases over to others, but again, we found that without having those contacts, that was very difficult. We wanted to know a little bit about what our COVID cases were looking at. We had early in the pandemic, of course, we were hearing what was happening in China and in Italy and other countries, but we weren't sure exactly how this was going to affect us here in the U.S. and certainly not in our region here in Kansas City. And we really wanted to come up with some ground rules of how we would go about sharing this information across the health systems. So just to give a little background, this is downloaded as of just a couple days ago. We've exceeded 10,000 cases in the state of Kansas for COVID positive cases. And if we look at it from a positive cases per day, you can see there's been ups and downs on certain days, depending on, I think, a lot on testing capabilities, and also reports of cases from outbreaks in certain facilities, such as the meat packing plants and so on. And then you also notice there was a change in the reporting structure to every other day that occurred after May 11th. But the red line shows that average, and certainly over the last month, the last 30 days, we've seen a leveling off of the number of cases per day, thank goodness. When we look at it on a county level, which affects here, us in Kansas City, certainly in Wyandotte County, there were more cases cumulatively than we had been seeing in Johnson County, and exceeding the number of cases by 500 to 600. We were able to obtain recently some information from the state of Missouri so we can compare, and you can see state of Missouri, as of recently, reported now over 14,000 cases. Don't have that same daily average line that helps me kind of understand what's been happening in the state of Missouri, but I think you can get a pretty good idea that at some point early in May, there was this peak that occurred in the state of Missouri, and ever since then there's been up and down in terms of the number of cases on a daily basis. Unfortunately, I don't have the same county information for Jackson County or Cass County to help report to the group. So the second goal here was, or that first goal was really to understand what our surge capacity was. And so we asked each of our 15 critical care sites directors to give us an estimate of their current capacity in terms of ICU beds, their number of providers that they have available, including even critical care fellows or pulmonary critical care fellows or advanced providers, with the idea that if we had to go into a surge capacity, we would be utilizing those people just like our intensivist. And so you can see we have about 220 some in the region. And certainly we did not hit every hospital within the region, just those 15 I mentioned at the beginning. But so we could be up to, I think, comfortably in the mid 200s for our region. On average, you can see there are about 14, or median would be around 6 critical care providers per site. The ICU beds across those facilities were a little bit over 500, with close to about 500 ventilators. And so this is current capacity, again, with that median being around 23 ICU beds currently available. What was interesting was the last 2 columns, which is the surge capacity assessment. And this was refined across those sites over a few weeks, because really understanding what that surge capacity early in the pandemic was a moving target. For example, here at University of Kansas, we had to ascertain the operating rooms that we have available, how do we open up those operating rooms to function as an ICU bed, and what is our capacity in terms of ventilators. What is reassuring is after that surge capacity is that we would have, in essence, over 1,000 ICU beds available in this region with over 1,100 ventilators in current availability, not necessarily from the stockpile. So this was the first time we've ever had that piece of information, which again was very reassuring as we were trying to prepare for this pandemic. We next asked the group to contribute information in terms of their active cases, in terms of COVID positive cases that were in the ICU, how many of those were on the ventilator, how many were pending in terms of diagnostics. As you know, early on in the pandemic, diagnostic turnaround was quite delayed. And then what were the non-COVID ICU cases and how many were on the ventilator. And what the census date time shows you here is that we had different levels of cooperativity. There were about half a dozen hospitals that did keep up with this COVID census on a daily or nearly a daily basis. And then we had some that contributed no information and others that, you know, contributed information initially. And some of the health systems, again, really did not allow contribution of this information, even in aggregate. This was given in a secure database, REDCap database, and was only available in terms of their specifics to the individual institution. And so, again, one of our challenges is getting that level of cooperativity. But I just still think we were able to—
a 2 minute, sorry.
Okay, give a little bit of a picture of what our COVID positive cases were. And you can see here, this is based on 160 cases. We used 30 cases as comparison. And for our COVID positive cases, you can see that the average age was a little bit older than the non-COVID cases, and significantly so. And then in terms of gender, it was pretty even for both COVID positive and COVID negative cases. Ethnicity, I was expecting to see more Hispanics, and indeed there were more Hispanics that were COVID positive, as well as more African Americans. You can see here 42% of the cases being African American, and this was statistically significant when looking across those race categories. We were very interested in what was happening in terms of ventilation in these patients. You can see in terms of non-invasive ventilation, there was actually a predominance of use in COVID cases and not a significant difference in terms of actual invasive ventilation. And then not too surprisingly, given kind of our management of these patients, we early on adopted prone ventilation, and about a quarter of the cases actually did do prone ventilation that were COVID positive. Lastly, the use of pressors, we ascertained about a quarter of the cases. Renal replacement therapy was about 14%. This was very important because in some situations in areas in the United States and elsewhere, renal replacement therapy was occurring in up to 30 to 40% of cases that need, and we were concerned that we would outstrip our capacity here in the region, but fortunately we did not. And you can see the tracheostomy cases. Lastly, the characteristic, we were trying to ascertain how many of these were immunosuppressed, about 28%. And we did have 3 patients that were COVID positive that were pregnant. Lastly, in terms of survival, you can see that the mortality in our region was around 14% for COVID positive cases. And certainly, I think comparatively is certainly consistent with what we're seeing around the country and maybe even on the low side. And a lot of these patients do have prolonged hospitalization. So you can see of this cohort, only 50% of them actually achieved hospital discharge. So a lot of these patients are in the hospital for long periods of time. So just to end, I think in preparation from the inpatient side for the COVID pandemic, we realized quickly how important a regional response and coordinating that response was essential.
We, I think, successfully accomplished the surge capacity part of this, and this was a very helpful forum for us to discuss amongst our critical care colleagues and our public health experts that participated in this weekly discussion. But it also brought up some gaps in healthcare, and that this cooperation across the health system and across our state barriers really impeded our ability to track these COVID cases much more diligently. And I think this is a wake-up story for us, you know, and certainly of COVID-19 in many ways, but always the concern of a resurge or other public health emergencies and epidemics would, I think the mechanism we've had in place is a good mechanism, but really trying to get a more complete picture of the region at hospitals that were not contributing data would have been helpful. These are the group that the critical care directors that met on a regular basis from the region. And these are the public health partners that also actively participated from the region in our critical care directors and all in there. And thank you very much to all of you.
Wow. Thank you very much for sharing that perspective. That's amazing what you've been able to accomplish so quickly, Dr. Castro. So thank you. And now I'm going to kind of keep us moving along in the interest of time. We're running a bit behind, but I'm going to turn it now next to our healthcare outpatient perspective, which is on rapid transitions to telehealth and prioritization on testing. So we have Dr. Brett Sperry with St. Luke's Mid-America Heart Institute and Assistant Professor of Medicine at the University of Missouri, Kansas City. So Dr. Sperry, the floor is now yours.
Sounds good. Thank you. I am just wanting to make sure that everything comes up. I went to the last slide first. Here we go. All right, so you guys can see my screen and hear me well? Great. So I'm a cardiologist at St. Luke's. I'm a heart failure transplant cardiologist, and you know, all of us were kind of repurposed into various different roles during this process in order to figure out how to deal with patients and patients coming in and patients outpatients. And then what do we do about all the testing that we have ordered or we're planning on ordering for patients, cardiovascular testing and other testing, and how do we prioritize them? And so that's what I'm going to talk about here for the next 15 minutes. I don't have any disclosures related to this. And I just want to highlight a few of the many members of our team that has made this framework possible and our response possible here. So what I'll talk about is the scope of the problem, the challenges, solutions that we've come up with, and then what is our path forward. So I'm going to make a few statements here, and I think we all understand these. The coronavirus COVID-19 viral pandemic poses and continues to pose a unique and unprecedented challenge to the United States healthcare system. As other speakers were talking about, the immediate priority initially in the early stages was for healthcare organizations to shift towards accessibility and increased resource utilization for infected patients and away from less urgent testing. And number three, patients with cardiovascular disease, understanding that they will continue to present with acute and chronic problems during this pandemic, which can lead to uncertainty regarding how do we postpone procedures and testing, what is the priority, and then what do we do with our outpatients who have been scheduled or who are planning to be scheduled in the future. There are three potential responses to this pandemic. Number one is to just cancel all things elective, and then that gets into what is the definition of elective. Number two is business as usual. Continue doing what you were doing before and see what happens. Number three is somewhere in between, and I think health systems across the country have done any one of these three responses. We chose a path of do somewhere in between a more patient-centered approach to outpatient testing and prioritization of testing in office visits. And then when you pick this path, how does this come together? You obviously need leadership in your institution and in your department and division in order to make some some things like this happen. So what we decided to do, and this is spearheaded by our hospital leadership as well as Mike Main, who's the CEO head of our group, was to convert and organize our hospital, our cardiovascular division around task forces and inpatient, outpatient, and cardiovascular testing and procedures. And so these task forces had different aims. Number one, to develop a risk stratification tool defining urgency of cardiovascular testing and procedures. Number two, apply this tool pending and future tests. This is for aims for regarding to the testing and procedures task force, while allowing for patient-centered decision-making. And number three, create real-time strategies and policies to safely resume testing when the limitations are alleviated as caused by the pandemic. And so again, we created these three task forces, and I'll go through these one by one with a real focus on the outpatient and the procedures. So our outpatient task force was headed by Deepa Upadhyaya, one of our cardiologists. She was tasked with creating a virtual visit and medical record platform, which was built into our Epic. And Sanjay Gupta, who's one of our cardiologists, also very interested in IT, has also been very important in getting this to work and build all of this. Coordinate conversion of outpatient visits to virtual visits, and then create an algorithm for patients who need to be seen in person. This was all done very rapidly. I'm not going to spend a lot of time on this, but you know, I saw there are an unlimited number of funny pictures or memes with when it has come to the coronavirus, and one of them is from someone who said, I've been alive for 4 decades, you know, the 70s, the 80s, the 90s, the 2000s, and March of 2020, because every month seemed like a decade. And so when you're looking back at everything that happened here, I think it's helpful to show that you know, when we converted basically all of our patients over to virtual visits was something that took almost this whole time to develop, and was done relatively in the early phase of things here, which was on March 16th, which was right after it got real for everyone, which was when the NBA closed down, when Tom Hanks had this, when the WHO declared this as a pandemic. This is when we started to think, you know, at least that this is the real deal. And just to show what I was doing, you know, I was watching the Royals game here in Arizona from March 4th to 8th during all this was happening. So so we started virtual visits here on March 16th, and essentially we use Epic, we use Doximity Dialer, Doxy.me, FaceTime, Google Duo, mostly Epic Video if we can. During the first week, before that, we had 0 historical video visits, pretty much. And in the first week, we converted over 1,000 patients to virtual visits, telephone and video. By the third week, we actually were able to increase the number of outpatient visits by 25% compared to what was budgeted for that time of year. And that is mostly from shifting from doing a full day of clinic and shifting video clinic and shifting docs over from inpatient to outpatient rotations. And we essentially have done all virtual visits until about a little over a week ago, when we started to gradually filter new patients into our clinic. The second has to do with inpatient, and Bethany Austin was the head of this task force. And we heard a lot about inpatient already, but this gets down to the crux of everything that we do for inpatients, streamlining inpatient staffing. How do we interact with our fellows and with our nurse practitioners and physician assistants, our advanced practice providers, you know, limiting their contact and contact of extra people in the hospital with patients. shifting docs again from inpatient to outpatient work, creating the documentation language for both inpatients and outpatients to show that we're limiting our contact with patients because of this pandemic. And then we've instituted and initiated a lot of robotics into this, communicating with patients of interest. And then so I'll go into spend a little bit more time on the procedures and testing task force, which I was a part of, along with my colleagues here, including Anthony Migalski, who is our head. And we were tasked with creating a hierarchy for testing urgency and then facilitating review of previously ordered tests and procedures and applying this structure. And so here is what we came up with. So we came up with four priorities. So priority 1 is urgent inpatient or urgent outpatients, which we wanted to get done immediately. Priority 2 was higher priority. We thought within 1 or 2 months, we realistically could get to these patients. Priority 3 was lower priority, 2 to 3 months, and priority 4 was truly elective or low priority. We thought maybe 4 to 6 months. Now, remember, we put this into place in the beginning of March, and so we had no one really had any idea how this was gonna pan out and when we could start getting to these various priorities. But we always prioritize doing priority 1 patients immediately, if we could, and then priority 2, 3, and 4, we deferred them until the appropriate time. You can see some of our examples here, and I guess I cut off what each column was, but this first column was echo. The second column was, this third column was coronary angiography. And the fourth column here is EP. So basically what you see here is a overview of essentially all of the types of procedures that we do in cardiology and assigned priority to these. And there may be discrepancies about what people think one versus the other. This second one is heart failure here, but this is what was decided upon as a framework to take the queue of patients who were already in the system to have testing and to reprioritize them. And then how do we, to give guidelines to providers to move forward with testing in the future.
Just gonna touch a minute.
Okay, so this was done with section head and support staff. Referring physicians were kept in the loop. Again, this was built into the current orders for the EMR with a hard stop. You had to pick 1 to 4 for future orders. And then this was built into a dashboard so that we could, so that the schedulers could see all of the priorities going forward and then reschedule as needed. We did all priority 1 tests immediately, weekly meetings for all of these task forces that we had, at least weekly meetings to go over various things, constant discussion between leadership, responsive to the situation on the ground. And just to finalize some of the things that we did here, we began scheduling priority 2 patients in the 5th week after starting this. And then around that time, all patients who had a procedure that was thought to be potential for aerosolization underwent a coronavirus test prior to that within 72 hours. And then all patients admitted to the hospital were being tested as of the 8th week going forward. I wanted to just take a second to talk about leadership here, and I think these 2 quotes are very important. The ultimate measure of a man is not where he stands in the moment of comfort, but where he stands at time of challenge and controversy. And then in any moment of decision, the best thing you can do is the right thing. The next best thing is the wrong thing, and the worst thing you can do is nothing. So I think our hospital leadership lived by these 2 quotes. You know, you may not get everything right, but you have to do something and pick a path here and really be proactive with everything and expect the worst and hope for the best. So in conclusion, again, I think our leadership was astounding here. We over-prepared, which is very important, very frequent communication. patient-centered approach to non-emergency cardiovascular care we thought was well suited, and we think it has helped. It anecdotally has improved co-worker morale because we've heard from many of our nurses and MAs and others that they feel that by taking this type of approach, we prioritize each other and themselves as well as patients. And the framework developed during this first wave will be essential in case there are additional spikes. And we now have all of this in place. And again, hoping for not additional spikes going forward, but we are prepared in case that happens. Thank you.
Great, thank you, Dr. Sperry. That's really great. All right, I'm going to keep us moving along. We don't want to keep us continuously moving behind. So our next speaker will bring in a community-based organization perspective. For those not following along on the agenda, we've moved around a teeny bit, but we're getting back on track. So we have our next speaker, community-based organization perspective on rapidly scaling a community-driven home delivery meals program, basic needs launch change. So we have Cindy Terryberry, a community services liaison, and Dr. James Stowe with the Mid-America Regional Council. So the floor is yours.
Great, thank you, Stacy. All right, and just checking, can you all see that okay?
Yes.
Yes.
Okay. All right, so I'm joined by my colleague, Cindy Terryberry, and she is our community services liaison and really stood beside me as we dramatically changed our nutritional programs, home delivered meal programs out of the Mid-America Regional Council, really at the start of the pandemic. And I'm happy to hear the two hospital perspectives and CMS perspective about really shifting healthcare to where people want and need to receive it, which is in the community. You know, I hope more and more in the future that happens, less gleaming towers of hospitals and more care in the community where health really accrues. And certainly nutrition is a part of that. So as the pandemic ramped up, we asked our primary home delivered meals partner, which is a for-profit company that produces meals in Jackson, Mississippi, Pearl, Mississippi, actually, and drives them up to Kansas City and then distributes them here. We asked them to double deliveries to our existing clientele on March 12th to start preparing for the stay-at-home orders and the kind of drivers of nutritional need that would result in the community among older people and individuals with disabilities. They were able to do that for about a couple of days, and then the burden was too much, and they had to go back to the old model. Really weren't able to accrue additional clients. So as that was happening, really not meeting our scaling expectations, we had been having community conversations about a new nutritional model that would emphasize client choice, local foods, and using local community-based partners to get those foods into the system and into the homes of clients. And also that those foods would have some ability to be packaged individually for each client and have medical sensitivity. So we just simply accelerated that new model and kind of changed how it was being delivered so that it could increase capacity. There weren't food shortages in this country at the start of the pandemic. There weren't. There was plenty of food. However, the form of that food, there were certain types of foods that did have a shortage. And one of those was prepared meals that met federal nutrition requirements for kind of vulnerable populations. And those prepared meals went to the highest bidder almost immediately. Demand skyrocketed, and we had no suppliers across the country to get more meals, prepared meals, into the Kansas City region. Fortunately for us, a sister area agency on aging in Springfield, Missouri, have been dabbling in a new model of producing frozen meals at industrial scale or commercial scale, scheduled to begin on April 1st, 2020. And they accelerated their initiation also. And by March 30th, they got everything up and running. And on March 26th, this is what we saw rolling into an emergency warehouse from Springfield, Missouri, 20,000 frozen meals ready to go out to hungry clients in the Kansas City region. And so now I'm going to turn over the floor to my colleague, Cindy. She's going to tell you kind of what happens now to these meals, and we'll tell you the story about how they make it to people's doorstep.
Thank you, James. The plan of action that we put in place was to secure a warehouse space with freezer, cooler space, and dry space for repack and dock access. And that was a challenge in itself because the cold storage facilities around the Kansas City region, USDA had stockpiled commodities and other things, so there was no cold storage space available. And we were lucky to find a community partner that had half of a warehouse that they gave us free of charge to use. We've been using that warehouse since March 30th. Our first meals were delivered to clients on March 30th. We had developed a no-contact meal delivery system. Dr. Stowe actually wrote a manual for all of our volunteers and staff that were delivering these meals to the clients in their home, no contact delivery. We had to respond to the congregate meal service being ended on March 16th when all of our senior centers closed down in 5 counties around Kansas City, and we needed to be able to provide meals to these people to keep them in their homes, to self-isolate, not go to the grocery store. So we started delivery, like I said, on March 30th, just 2 weeks after we started this project. The meal deliveries are twice per month, every other week. They receive 10 frozen meals, 10 different menu varieties. They receive 1 loaf of freshly baked farm-to-market bread, 8 grain bread, 3 grams of fiber, 10 cartons of fresh fluid milk is what we started providing. We found that a lot of our older adults don't drink as much milk, so we now provide 5 cartons of fresh fluid milk, 1%, and 5 hot chocolate mix, which is equal in calcium values. So we provide that. 10 servings of fruit. We originally provided 10 fresh fruit. We found that the clients couldn't eat the fruit that quickly, so we're now mixing fresh and shelf-stable fruit cups. And the clients that we're serving are 60 plus, so we really had to keep in mind what types of foods that they would eat, and we had to follow the guidelines of the Older Americans Act. So that was the challenge, and that's why we were so fortunate to have senior age. And we also received meals from Eskenazi Health in Indianapolis, Indiana. We had gone to Indianapolis to view the model that they had in their meal provision up there and in October. So we were familiar with them, and they were able to, they did have the capacity to provide 10,000 meals to us. And today we've received over 107,000 meals. We have about 20,000 meals packed in boxes ready to deliver right now in the freezer, and additional product to pack. So we've provided quite a few meals to the community through this project. This is the new freezer that we're getting ready to move to this new warehouse tomorrow, actually. We should start production up on Monday. This is a freezer that we had already contracted to build at Canby's Market in Kansas City. And that was our goal, is to have our repack operation out of that warehouse. Unfortunately, the freezer wasn't completed in time. So like I said, we were fortunate to find a community partner to offer us half of their warehouse space and the freezer and cooler space so that we could start that response right away to the community.
And you'll notice that generator there at the bottom right, that's a Chevy 350, is that the right engine? Natural gas powered with a turbocharger. You know, we're always thinking about redundancies in safety systems and that type of thing. So if there's a power outage, that puppy will fire up on the natural gas line and run the freezer and cooler at Canby's perpetually until the power is restored. So that effort, I mean, it was a monumental effort. Cindy and I, other Mark staff, a whole host of community partners rolled up our sleeves and just got this job done. Really, as Cindy stated, the intent was to help people maintain food security during this very difficult time and stay self-isolated. So if they didn't want to have to go to the grocery store, they didn't have to. And if they didn't want to rely or couldn't rely on their traditional sources of food support, people coming in their home to prepare meals or family members driving around and delivering it to them, they could rely on us for that period of time. And that resulted in an 85% increase if you measured our February service 2020 to April 2020 service. In April 2020, 67,000 meals were delivered to nearly 3,200 clients, helping them kind of maintain that, that self-isolation at home and have some nutrition available to them. So, you know, this obviously this does not happen with one organization, and that's one of the key functions of collaboration in this region, getting everyone together, getting all the nonprofits together, focused on a critical task like this. And it has been exceptionally gratifying to be a part of it. So that's what we've done. We hope to see you all sometime, maybe at Canby's Markets, if you want to drop by and see how the operation runs there. When you feel safer to do so, we'd welcome you. And it's our intention to take this model into the future, have this be our primary model. Again, deliver choice to clients in the future, be able to pack their box with the type of menu items that they want and need, and then be able to be responsive to their medical diagnoses and help them thrive just a little bit better in the community. And if you want to reach out to me, or if you have questions for Cindy, I'll pass anything along as well, but there's my contact info.
Great. Thank you so much, James and Cindy. That's wonderful to hear what you've been able to accomplish. So thank you. Great. So our next speaker, we will move on to hear now from a philanthropic, a foundation perspective. We will hear Health Philanthropy's goal in COVID-19 response and recovery. And we have Kiana Thomason, who is the president and CEO of the Health Forward Foundation, joining us today. So Kiana, the floor is yours.
Thank you, Stacy. I appreciate that. First, before I get started, I just want to say thank you for the invitation, and also thank you to all of our healthcare workers and leaders for all of your courage and your commitment and your sacrifice for our community. So thank you very much. So just really briefly, Health Forward Foundation, for those who might not be familiar, is a public charity foundation, 16 years old, serving all of Kansas City and 3 counties in Missouri, Jackson, Cass, and Lafayette counties, and then 3 counties in Kansas, Wyandotte, Johnson, and Allen counties in Kansas. We grant make about $200 or $20 million a year, and since inception have provided over $300 million in funding to our community. You know, I would describe philanthropy's role in the COVID-19 response and recovery as highly collaborative, as highly adaptive and nimble, and highly compassionate. So Health Forward Foundation responded, or thus far, in around our areas of our core competency. We provide leadership, advocacy, and resources that eliminate barriers to health and promote quality health for the uninsured and the underserved in our service area. That's our mission. And so in doing so, our response thus far has been both administrative to our grantees as well as with resources through funding. Out the gate, we knew that we needed to be very responsive and support our partners in the way that was meaningful for their urgent needs, urgent monetary needs. So we converted all of our existing grant dollars to core operating funds so that our grantees could use the funds how they needed the funds. And knowing that this was less about whatever program that they may have applied for or written up or proposal, this was really just about their sustainability and their ability to meet the needs of our vulnerable community members. We also did advanced payments for grantees through the middle of the year and converted or changed all of the reporting, either suspended it or deferred reporting, knowing that our partners did not have time to focus on the administrative elements of grant-making processes. All of those changes are core tenets of what's called trust-based philanthropy. And it's been an aspiration of the foundation for quite some time to move more toward that concept. And the COVID-19 pandemic really just thrust us into changes that we had been wanting to make, but had been, of course, doing with a lot more, or being more measured in our implementation. And the crises allowed us just to jump in quickly to best practice principles around trust-based philanthropy. So some things will stick relative to those actions. The other thing that we did was work very closely with our board to allocate $3.7 million in response for our partners. And that $3.7 million has been allocated to our safety net medical providers, the FQHCs, the FQHC lookalikes, the smaller neighborhood clinics, as well as behavioral health, community behavioral health centers, community mental health centers, emergency funding to both those categories of providers. We knew they were struggling considerably with PPE, as well as with, quite frankly, demand destruction, knowing that revenue was dwindling fast as many of our safety net providers were only seeing very urgent needs for care that was COVID related. So knowing that demand destruction was happening, it was important for us to get checks out the door very quickly to them. I need to call out that we did this very collaboratively with other funders. We wanted to lessen the burden on our safety net partners and ensure that they weren't having to go to 5 or 6 different foundations to ask for support. So we jumped in and did that on their behalf and approached our FQHC partners first and later our behavioral health partners and others to say, submit one request to us and we will deliberate over that and coordinate and align our funding in response to your needs. And so did that with the REACH Foundation, the Wyandotte Healthcare Foundation, and the Hall Family Foundation. So I want to give a shout out to our peers in philanthropy and thank them for their work in support of the community. We also wanted to be able to stabilize as best as we could the essential services needs of our community. In doing that, we provided a contribution to the COVID-19 Kansas City Rapid Response and Recovery Fund that's administered by the Greater Kansas City Community Foundation. Also partnered in that effort is Mark Lisk and United Way. This fund was raised very rapidly. It felt really good, and it always does because Kansas City always comes through. That fund grew very quickly to 19 million, and several organizations, nonprofits across our community are accessing those funds. I think our fund, I'm on the advisory board, we're in the 4th round of funding for nonprofits in the community. So, you know, everywhere from grassroots organizations to larger organizations have received funding, and we continue to allocate those funds. I think it's really important to call out that the advisory board of that fund is very diverse and includes not just philanthropy and corporate funders, but also grassroots organizations and the different actors and players who hold the trust of communities as a part of the grassroots organizations. Having a diverse mix of advisory board members in philanthropy that's very inclusive is new to philanthropy in Kansas City. And so I'm very proud to say that board is fostering inclusion and belonging and representation, which of course filters down to representation in terms of where funding goes. So that's an important call out. We also, in the essential services category, focused considerably on food and childcare. So making sure that the large organizations like Harvesters, as well as the smaller organizations, receive emergency funding. We know food security or insecurity is a significant issue, more importantly, nutritional insecurity, as often food is present, but not whole foods, good foods. And so we wanted to partner to ensure that we close as many gaps as we could around that. We also partnered with the YMCA of Greater Kansas City to offer childcare services for our safety net medical and behavioral health providers. Of course, school was closed very abruptly for all of us. None of us had a plan for that. And we did not want childcare to be a barrier for our safety net partners, and especially those who were either uninsured or underserved themselves. And so that funding pool is for low-wage workers, safety net providers. And so we are seeing organizations like Swope Health, Samuel U. Rogers Health Center, and Truman Medical Center take advantage of those funds for their certified nurses, assistants, and techs and frontline workers. And so we are very happy to be able to provide those necessary services, which continue at least for the next month and a half. The other significant competency of Health Forward is to advocate with our community and on behalf of our community. And as we watched the health injustices manifest within our metropolitan area on both sides of the state line for communities of color, and we began to watch the data unfold, we knew that there was a significant gap with respect to the data that was available for race and ethnicity purposes for not only confirmed cases, but hospitalizations and mortality rates. It's important to note that both Kansas and Missouri have been sharing race and ethnicity data for quite some time. But of course, there are gaps there, and some of those gaps lie across the ecosystem, but are particularly aligned around private laboratories. And so it's important, data is important, of course, because we can't change or improve what we can't measure. And so knowing that health injustices are a theme of the healthcare system, and COVID-19 was no different. We wanted to ensure that Missouri and Kansas governors understood the critical importance of closing those gaps as rapidly as they could. So we partnered with El Centro in Kansas City, Kansas, and the Urban League of Greater Kansas City, both organizations who are focused on justice and economic and community development empowerment for both the Hispanic and Latino communities and the African American community. We partnered with them to and submitted a letter to our governors in the bi-state area. Both Governor Laura Kelly and Governor Carson have had over 75 organizations listed as supporting and endorsing organizations of that effort, asking them to ensure that they quickly close the gaps and require that laboratories and the healthcare ecosystem report race and ethnicity data, and they in turn close the gaps and make that publicly available. I want to thank some of you on this webinar who signed that letter. We appreciate your partnership in that area. So that is by and large how Health Forward has involved or responded to the crisis. We have about $700,000 remaining in our resiliency fund that we are working with several different community stakeholders around coordination for testing and contact tracing in communities of color. And as well as wraparound services for self-isolation that for individuals and families who sometimes will choose not to self-isolate because of essential needs. That's the reality of how this thing is spread. And so our remaining funds will go towards that. And of course, we are continuing to work with different stakeholders around the lingering health injustices that remain and are exacerbating what already existed. So that is a synopsis of Health Board Foundation's role and work with other foundations and community.
Great. Thank you so much, Kiana, for your for the talk and also for your wonderful leadership and everything you guys are doing in the community. This is wonderful. Great. So now our next perspective will be from a research perspective. And so we will be hearing Navigating Uncharted Territory, Clinical Research at the Time of COVID-19 during the Pandemic Crisis. And so we'll be hearing from, we have two speakers. We have Dr. Donna Buchanan, who is the Director of Research at St. Luke's Health System, as well as Dr. Mikhail Kosibord, who is the Vice President of Research for St. Luke's Health System and the Director of the Cardiometabolic Research and Co-Director of St. Luke's Michael and Marla's Haverty Cardiometabolic Center of Excellence at St. Luke's Mid-America Heart Institute. So there's a mouthful. But we are, the floor is yours. So thank you, Dr. Buchanan and Kosibord.
Stacy, do you hear me and see me?
Yes, we do.
Okay, and is Donna on?
She is. I thought, I think she's sharing her screen. Is that right, Donna? No?
Yeah, I'm not sharing my screen.
Okay, Donna, I believe you're on mute still. You might have to unmute yourself. On the bottom.
Donna is not connected to audio right now. I only see her connected via video. Oh, she's connected on her phone. Would you like me to unmute you?
See.
Oh.
Yeah, here she is.
Now can you hear me?
Yes.
Yeah.
Okay. Good afternoon. So thank you for that introduction. And I think all of us know that given the potential extent of the pandemic and its impact on healthcare organizations, numerous measures have been taken to make sure that our patients and staff are safe. When it comes to our research organization at St. Luke's, we have several unique challenges. We have numerous obligations to our various stakeholders across the diverse portfolio of research studies that we are involved in. First and foremost, we have an obligation to the safety of our patients participating in the research and to the safety and well-being of our own research staff, as well as to the regulators and the ethics committees, the IRBs, and the study sponsors in order to maintain the integrity of the study that we and our patients have made commitments to. So in order to balance the potential risk of exposure for patients that may be at a high risk if infected by the coronavirus, especially those that are older and have multiple comorbidities, versus the potential benefits of being involved in study-related interventions, we had to really think carefully through the complex task of putting together some guidance for our staff and communicating that to our study sponsors in order to protect our patients to the extent possible while minimizing the disruption to our research operations. So in terms of our interim research guidance, we essentially started by, this was mid-March, recognizing that we really needed to suspend our in-person research contact with patients. There were exceptions to this if patients were already in the facility. If patients who were hospitalized or undergoing a procedure, they were at no greater risk of being exposed to COVID-19 than not. So for those, we continued for a period of time to interact and consent those patients for research studies. But over time, we ended up having to suspend those in-person research contacts with patients. The exceptions being for things like studies where it was actually at a greater risk for that patient to not participate in the study than it would be for them to actually potentially be exposed to COVID, such as oncology patients. So we did make an exception for those kinds of studies. We had to shift quickly to conducting study follow-up visits by phone and using telemedicine, as we've heard about today. And then we also had to think about things like, how do we provide investigational products, study drugs? How do we actually get them to patients and continue to do this important research? So some of the study sponsors arranged for, shipping investigational products directly to patients. We also developed at St. Luke's a process for actual curbside pickup for those study drugs if the sponsor wasn't actually providing them directly to the patients. As part of research, we typically have people that will come in on behalf of that study sponsor to monitor things and how things are going with all of those studies and how does the data look. Well, with us wanting to limit the number of people in our facilities and making sure that everyone stayed safe, we essentially asked the sponsors and monitors to do remote monitoring. And this was in line. We followed the Association of Clinical Research Organizations, their recommendations in utilizing just an electronic data capture approach. So just by looking at the data that was already being submitted for that study, monitoring it that way, rather than having our study staff provide source documentation, which would have been difficult to do as those staff were actually working remotely as well. We also had to think about communications with our sponsors, being in very close contact with them, as well as with the investigational or institutional review boards. While the regulations require that IRBs approve any type of modifications to a previously approved clinical research study, they also state in their regulations that except where necessary to eliminate apparent immediate hazards to the human subjects. So as many others, our opinion was that COVID-19 actually fell into that category of potentially presenting an immediate hazard to human research subjects. So for example, we worked with the sponsors to make immediate modifications to those protocols, such as consenting patients over the phone and making sure that we stayed in connection with those patients during those follow-up visits through telemedicine. So now, as that kind of process went on for a couple months, and then now as St. Luke's Health System is working to resume our elective procedures and return to that new normal and providing health care, while carefully monitoring that COVID situation, we felt it's now time for us to engage in that next stage of adjusting our research operations while keeping in mind our continual goal to protect the health and safety of our patients, staff, and our research partners. So what we are now in the midst of launching is a phased approach to now resume inpatient research activities with patients. And this would be for screening, enrolling, randomizing, and also doing those study encounters. So now we're in the process of, for open studies, looking at those first 3 rows, the very top one, we now begin in phase 1 with enrollment and follow-up only for patients hospitalized or undergoing a procedure, as these patients are already in the facility, and these research activities are putting them at no greater risk for exposure to COVID-19. In phase 2, we will resume inpatient or in-person patient follow-up for patients already enrolled in studies who are coming into the facility for clinic visits or standalone research encounters. And then for studies that were opened prior to around March 16th, in phase 3, we will resume in-person enrollment of those patients who are coming into the facility only for research purposes. And then finally, for enrollment of patients in new studies that we have continued to work on during this pandemic, we will begin enrolling them in those new studies during phase 4. The question now is, how long will each of these phases last? We will continue to monitor the COVID-19 situation and how things go. We envision taking this in a very slow, methodical approach and potentially having each phase last for approximately 2 weeks, depending upon how the situation unfolds. That's a little bit of an overview of clinical trials, but I also wanted to share with you some other things that we've done at St. Luke's Health System in the midst of this pandemic. And one of them is, how do we respond to all of the new proposals to be involved in COVID-19 research? As this unfolded, we began getting a number of these, not only to participate as a site in COVID-19 research, but also our investigators were putting forth their own ideas for research that they wanted to do. So we developed a research COVID-19 steering committee. It was made up of research leadership, PharmDs, and physicians in the areas of critical care, infectious disease, and emergency medicine, excuse me. The real mission of that steering committee was really to centralize the coordination of that research of COVID-19 in the healthcare system, and to critically evaluate the investigational and therapeutic options for COVID-19, prioritizing those research opportunities that provided access to therapeutic options or information that had the greatest potential to influence outcomes, and to minimize redundancy in our system, and to appropriately vet these proposals from a financial, legal, and a regulatory standpoint. This also gives us an opportunity to think about, how do we expand research within the St. Luke's Health System? Right now, research happens primarily at St. Luke's Hospital on the plaza, but we also had, especially in the midst of COVID-19, physicians that really wanted to make available COVID-19 potential treatments for patients that were at our other metro hospitals, such as St. Luke's Hospital North, South, and East. So we had to think about, how do we do that? And we met with our medical executive committees to actually have them review and pass a resolution giving approval for research to take place at those other metro hospitals for COVID-19 research. We also had to think of other kind of logistics, whereas when we have research going on at the plaza, our ancillary services are well attuned to providing the services that we need for research. But we also needed at these other metro hospitals to think about things like, how are we going to engage pharmacy, lab, imaging services? In doing those things, we feel like we've actually been able to push the research agenda further than we would have had COVID-19 not happened. As we've said in other presentations today, this was an opportunity for us to push things forward and do things in a way that maybe we had on our list of things to do, but this gave us an opportunity to really push forward.
I'm going to give a 2-minute warning.
A couple other areas that I will end on then is St. Luke's involvement in different types of studies. I'm actually going to let Dr. Casaboro comment on a couple of these, but just to highlight them, St. Luke's Health System launched a global COVID-19 study, the DARE-19 study, and we also were involved in leading the Chief HF study, which is a study looking at heart failure patients, but it's the first clinical trial in the nation that will be done completely virtually through mail, smartphones, and wearable technology. Dr. Casaboro, do you want to add anything on those?
Well, thanks, Dana. Just to briefly add that, again, there are certain things that we were able to do because of the urgency of the situation, and DARE 19 is the first not just multi-center trial, which we've done several in the past, but global, international, multi-center trials that we are coordinating and are the global sponsor for in multiple countries to try to understand whether the concept of organ protection can reduce the risk of disease progression and death in patients hospitalized with COVID-19. So it's really incredible where this particular trial that normally would take about 1.5 to 2 years to organize actually was able to enroll the first patient within 30 days of us actually starting to put it together, putting a team together to organize a trial. So really a fraction of the time that normally would take. And then Chief HF is really a great example of trials that's been completely virtual. And it's one of the very few, or perhaps maybe the only trial that certainly I'm aware of during this time period that's continuing to enroll patients well, because it is completely virtual and does not require any in-person interaction. And I think we're going to see lots and lots more of this kind of revolutionary approach to clinical trials in the future, in part because of the COVID-19, in part because it's actually the direction in which this field was going already, but it just got incredibly accelerated by all the events.
Great. Was that all for you, Donna and Dr. Casaboro? Didn't want to.
Yes, thank you.
Okay, great.
Yeah, thanks. Thanks, Stacey.
Both so much. Very interesting efforts you've been doing in this new normal. So thank you. Great. And so we'll move on to our final perspective. So now we'll be hearing from a safety net provider, an FQHC, a perspective there on post-COVID-19, the path towards health equity. And so we're fortunate to have Jaron Raven, the president and CEO of Swope Health. And so the floor is yours, Jaron. Oh, and I think you're still on mute. There we go.
I am off mute now. Thanks, Stacey. I really appreciate it. First, I'd just like to say thanks to everyone for your work, and Stacey for allowing me to share our experience at Swope Health. This is a unique and challenging time. Really appreciate everybody's kind of aligned, concerted effort to deal with COVID-19. So from that, I'll go ahead and let me share my screen here. Screen up. Okay, great. One second, Stacey. Presentation mode.
Yeah, like it's like the bottom, like that bottom toolbar. There you go.
Got it. So sorry. All righty. A little bit about Swope Health. All right. Swope Health was founded in 1969. We have 9 clinical sites around the Kansas City metro area. We're bi-state, Kansas and Missouri. We have 4 residential treatment sites, 1 outpatient treatment center. We have an annual operating budget of around $6 million, accredited by Joint Commission, CARF, and NQCA. Currently employ over 600 associates. So we look at the overall trend of COVID-19 cases in the Kansas City metro area. If you recall, the projected peak moment was, I think, April 28th. We saw cases continue to rise even after that. We did see a successful mitigation efforts begin to work around beginning to middle of May. Unfortunately, now we know that Kansas City is up 24% in the last 7 days of COVID-19 cases. So still have work to do. Okay, let's talk a little bit about the disproportionate effect of COVID-19 on certain populations. So in Kansas City, African Americans are 29% of the Kansas City population. They are represented, disproportionately represented in COVID-19 cases, so around 40%. The Latinx community is about 10 to 13% of the population in Kansas City metro area. As you can see by the graph here, they're around, although representing other race groups, they're around 25 to 26% of COVID-19 cases. So you have to ask yourself why that is. There's been a lot of studies and articles written about the reason why some of these vulnerable populations are overrepresented in COVID-19 cases. So why is this? All right, COVID-19 or coronavirus disproportionately affects people of color due to underlying health conditions. Adults with low income are more likely to have higher rates of chronic conditions. African Americans are 3 times more likely to die of COVID-19, and the Latinx community is two times more likely to die of COVID-19. And the reason why is clearly there's underlying health conditions, comorbidities, cancer, asthma, diabetes, hypertension are just some of the chronic conditions that are extremely prevalent in both of those communities. Now I'm going to talk a little bit about the kind of perspective, what we've seen at Swope Health, testing and being in the community. So a little bit about how COVID-19 impacts those vulnerable communities and populations we just talked about. One, it further impedes access to healthcare. As you know, and as mentioned earlier in this presentation, a lot of providers have canceled non-critical appointments. There's clearly telehealth challenges. Many of us as providers have utilized telehealth, but certainly not to the extent that we're using it now. Also, there's an inability to practice social distancing, or at least a challenge, right? Some of these communities that we just discussed are essential workers. They don't have the ability to work from home due to their job functions. They take public transportations. Many of them work in meatpacking facilities or auto facilities. They also live in multi-generational housing, which means that they're likely to be amongst a number of different individuals in the home. There's also the information challenge, right? During this COVID-19 timeline, there's been a number of information that's come out, that's been retracted, that's been changed, that's been modified. And so when you don't have access to information, or you're not sure of the information, that's can cause the challenges. And at this rate, we know that the information regarding COVID-19 can be deadly. So having the right information is something that's critical. So for Swope Health, we've tested over 1,200, we've done over 1,200 tests, mostly pop-up tests, not at Swope Health Central or our other 8 locations, but out in the community. And we're very proud of that. We've partnered both with Unified Government in Wyandotte County, as well as Kansas City, Missouri Public Health Department. We've also partnered with KCPS. We've partnered with KIPP Endeavor, some of the charter schools. We've seen and done testing at the Franklin Center in Wyandotte County, Lafayette Jesus Christos in Wyandotte County, Southeast Public Library, Kansas City, Missouri, KIPP Academy, of course, as just mentioned, Trails West Public Library. Hope Faith is a homeless shelter downtown that we've done testing there as well. Southeast High School, KCPS. So we've really been all over the Kansas City metro area providing testing to those who need it. Some of the key findings, our telehealth capacity has increased 90% since COVID, since trying to make sure that we are reaching our patients where they are. In addition to that, our mental health or behavioral health business is up 20%, particularly in telepsych. And so what we know from our business is that our mental health patients are seen about 16 times per year versus our primary care or medical patients are seen just twice a year. So our ability to continue that continuity of care to make sure they continue to receive services is critical. And so we've seen an increase both on the primary care side and the mental health side, particularly in telehealth. And the reason for that is, as many have touched on, there's been a number of policy changes and waivers that allows us to continue to provide services. So as mentioned earlier, the regulations and waivers on originating sites gives us some flexibility. There's been flexibility on collaborating providers and the ability to providers to not be in the same room or expand the distance in which collaborators need to have their collaborators or apprentice in the actual facility. So those have given us the type of flexibility that allows us to continue to treat patients. Just a quick note that the Latinx community or Hispanics only constitute 24% of the people that we've tested, although they make 70% of our positive tests. And a lot of that is due to the outbreak in Wyandotte County. So I wanted to make sure that was noted. So what do we do now, right? I think there's been a lot of discussion about the challenges of COVID-19, how it's impacting vulnerable communities, different ways that we've had to change our operations as healthcare providers to make sure that we are reaching those who need us most. But there is a question of what we do after COVID-19. What do we do to ensure that if there's another pandemic or even devoid of another pandemic, what are we doing to ensure that there is health equity, and that those in vulnerable populations are becoming and living in healthier communities. So here's a question: how can we pull together critical resources, thought leadership, and align missions together to reduce health disparities? I will go on to introduce a plan, and we'll certainly welcome your questions. All right, I am presenting, or at least offering up what I believe is a regional health assessment, a healthcare assessment. And what I mean by that is we would like to pull together all the healthcare stakeholders, thought leaderships in the region to start to think about how we align goals to drive change. That means building a coalition of organizations, gathering data, analyzing facts, developing recommendations, reporting those findings out, and then building consensus around what the outcome measures should be. Of course, we will need grassroots support. We need individuals in the community who understand what the challenges are, who are passionate about it, to back this initiative. Also, we need legislative support. We need, whether it be county, city, and federal leaders to find common ground in moving the region ahead. And of course, foundation support. Those who are on the line, like Kiana Thomason at Health Forward, who've been supportive of Swope Health and other safety net providers, would be critical in this type of initiative. This is kind of the way it would work at a very high level. An example of this is Accountable Communities of Health, or ACHs, in Washington State. What they did is provide, they broke up their state, and I'll show a map here in a moment, broke up their state by region, and identified regional goals for each kind of sectioned off area of the state, funded that initiative, and then had consensus around what the outcome measures would be. For some, and I'll go to this next slide, and here's a map of what I'm referring to. This is an Accountable Community of Health. This is broken down the entire state of Washington State by 9 different regions. And each of these regions focused on one particular or a number of particular outcomes. For Olympic Community Health, it was creating a paramedicine program to reduce ER visits. For Cascade Pacific, it was integrating primary care and behavioral health to increase access for both of those services. And so this is just an example of how a state or a region, an area, can break down, really can build a consensus around health outcomes, and then use different organizations to drive to that change. And luckily, there's actually an example here locally. So Wyandotte County has a community health improvement plan that was created in 2018. And from what I've read, they've gathered a number of community stakeholders and put together extremely aggressive goals in this plan to change what they're calling priority issues. So that is access to foods, access to medical and behavioral health care, an increase in jobs and education. And for each of those issue priorities, they identified a lead organization to drive that change. Just to be clear, they have a steering committee. Some on the steering committee is the City of Bonner Springs, Children's Mercy, KU. Those are some of the organizations represented in this plan. Here's an example of what I think we can do. So if we chose these counties, and this is actually the map of MARC, Mid-Atlantic Regional Council, Mid-America Regional Council, and the counties that they represent as an organization. If we chose these counties and find some alignment between all these counties and the cities within these counties to drive health outcomes. So first, we'd identify organizations in each of these counties who could be a lead agency. Secondly, find consensus around what the health challenges are. Thirdly, find consensus around what the outcomes should be regarding related to those health challenges. Then find the appropriate funding for each of these counties to identify and work towards improvement on these outcomes, on certain particular specified outcomes. And that is just a plan of how we can impact the health disparities going forward. The next slide is just a conclusion. So thank you, Stacey. I know that I probably beat the 15-minute mark and was the fastest, but I wanted to be respectful of our time being the last presenter. So thank you a lot for the opportunity.
Oh, thank you so much. That was wonderful. So now I'll turn it over to my colleague, Dr. Carol Decker, who will, I guess, lead us through some Q&A. We have about 10 minutes left. So anyone that has specific questions for any of the speakers, please do enter them into the chat box. I know there are some there.
Okay. All right. Now I think I might be ready. So thank you to all our speakers and to each of the members of the audience that have listed comments. including things like great work. So if you have other questions, don't hesitate to put those in the chat box or raise your hand. Dr. Castro, are you still on the call?
Yes.
So there was a question posed that says, do you see longer term opportunities in collaboration across the hospitals beyond COVID? Do you think there might be a culture shift to openness in sharing data and being more collaborative rather than competitive?
Sure. I think, you know, COVID is just one pandemic. We likely will see in our lifetime other pandemics. And I think this collaborative effort will help us in terms of addressing that as it comes up, as well as, you know, other metropolitan emergencies that we need to address on a critical care basis. I do think this was a culture shift because it arose from within our specialists, not from, it was a kind of a bottom-up approach as opposed to a top-down approach in terms of coming from hospital leadership. It was actually come from our teams that were working in the ICUs on the front line. And we recognized that this was really necessary for us to cooperate and be able to do the right thing. So that culture shift has happened, and I'm hoping that that will translate to leadership really understanding the importance of that across the health systems in our region.
Thank you. So as one of the members of the QVIC here in Kansas City, we've been trying to chase collaboration across the whole community and find that there's pockets of openness. And so we're hoping that it will also continue. So Dr. Sperry and Ms. Weininger, are you still on the phone? Still on the call, on the Zoom call?
Yes.
So someone has posted, do you think telehealth will wind down and care will revert back to in-person visits now?
I think that's a great question, and that's what we all, you know, all the healthcare providers here around me are asking ourselves. You know, what do you think of this telehealth? And I personally, you know, was in clinic today, and about a quarter of the patients I saw in person, and then the 3/4 I saw via video or via telephone. And I had 2 patients today comment that they really hope that the telemedicine sticks around at least through the fall and the winter, so you know, they can not have to come all the way into the clinic, especially if they're feeling okay, and they just want to speak to the physician, or you know, we can kind of do basic physical exam with video, certainly. So I think, you know, I think patients are going to really demand it, and I think doctors like it too. You know, it makes things a little bit faster for some reason to do video visits or audio visits sometimes. And I think the reality is that for a lot of stable patients, you don't necessarily need to see them all the time. You don't need to see them every 2 or 3 months and examine them. You know, you do need some in-person time, you know, at some interval, which can be decided. But for stable patients, a lot of times all you need is some good discussion and the history, and then deciding from there. So I think a big thing that Michelle has commented in the chat here is the payment. You know, if you see the payment for telehealth drop off dramatically, then I think it's going to be hard to use the same exact time slot that you would use for in-person for telehealth when they're already talking about cutting reimbursement for outpatient office visits, particularly for specialists like us in cardiology. So I think the payment is a huge aspect of it, and if that payment goes away, then I think we are going to probably go back to only in-person visits. Let Michelle comment.
Yeah, I'll just kind of echo what he said, and that's honestly that's what I'm hearing a lot when I talk to the medical societies and the hospital associations, and from individual doctors and hospital leadership is the reimbursement rate. But a lot of the flexibilities right now that are available are because of the 1135 waivers. And that pretty much goes around the statutory requirements. And that gives us during this public health emergency the ability to do that. A lot of what has been a barrier to some of the telehealth coverage for CMS has been statutory exclusions. And that's where, people were talking about reaching out to your congressional districts. Honestly, as funny as it sounds, it does literally take an act of Congress to get that changed. But what we're looking at is again, we're starting to look at what's working, what isn't, starting to gather feedback, because what we can move forward with that isn't going to hamper us statutorily, we want to start looking at that so we can go through the rulemaking process, so we can add things as we have the ability to do so. So in the chat box, I did include my email address. So after this meeting, if anybody has any feedback or they just want to talk about this with me or get more information, I am more than happy to pick up the phone and visit with you or have an email conversation or whatever. Because the information that I receive, I report out to senior leadership within the agency. So it's really good for us to have on the ground examples and feedback and input into that conversation.
Okay, thank you. Mr. Raven, are you still on Zoom?
I am.
So you mentioned that you had seen such an increase in the telepsych program. Is it something that you're hoping to continue to pursue? Is funding not as big an issue? I would think it would be a big issue, but what does Swope Health think about continuing telehealth?
No, so funding is always an issue, but let me see if I can. I heard an echo. Okay. Funding is a bit of an issue, but we certainly plan to continue those services. I think that the largest benefit that we've received from the waivers is it really was. Let me put it this way: we always had a challenge with finding psychiatrists in the state. The vast majority of psychiatrists in the state work for the VA, from what I understand, and so we've always been challenged with that. The waivers that we've been granted gives us the ability to find providers outside of the state to focus and meet the needs of our patients. So we certainly plan to continue to ramp up those services. I think we are going to try to lobby as best we can for some of these waivers to be permanent. If at a minimum, not ideally they would be permanent. If not that, we certainly want to prolong them as long as we can. But we intend to focus on that as much as possible.
Okay, thank you.
Thank you.
Are there any other questions that anyone might have for the panel, or we're approaching the end here?
Can you hear me?
Yes. Hi, Ms. Thompson. Yeah, you're kind of a garbled robotic, but.
I'll try to follow in, but don't worry about it. We're about to end.
Okay.
Is that better, or still sounding robotic?
Oh, now it's got an echo, a robot echo. So.
Oh, and now Carol's on mute.
So anything else that anybody would like to contribute, any of the speakers or any of our attendees?
Well, this is John Spurs. I just want to say, I don't think I've ever been so proud to be from Kansas City. I mean, all of these efforts, all of the thoughtfulness and intentionality and, what has happened in such a short time, it's just, it's breathtaking. I'm so pleased and proud to be in this community. And for all of you, as busy as you are, all the balls you have juggling in the air, to take the time to present all the work you've done is so greatly appreciated for all of us. And, it's just really inspiring. I mean, when, the going gets tough, I mean, the tough really can step up, and y'all have done such a remarkable job. And, at the QVIC, we're really trying to find what, our whole mission is around improving the value of healthcare in Kansas City. And I hope that, you know, we can be a resource going further as you try and transition from an acute survival mode into a more sustainable vision about how to improve the value of care in our community. And, you know, there's such great learnings, and learning from what each has done, I hope we can facilitate sort of more collaborations and leverage this great initial work to make sustainable change in our region. So thank you all so very, very much for presenting.
Yeah. Hey, Carol, can you hear me now?
Yes.
Okay. Thank you, Dr. Spertus. It's good to hear your voice. Really quickly, I think telehealth is critically important from an access to care standpoint, but I encourage all of us as we focus on coverage and that we focus also on the digital inequities that exist that pose barriers to many individuals who live in marginalized conditions, many of whom are people of color, especially our rural communities. Many of your health systems span into rural communities. It's important that we also advocate for broadband coverage for our communities so that we ensure that no one gets locked out of care, as I believe this will be a growing trend that will stay around. It's important that we leave no one behind, and also focus your advocacy efforts on digital equity and inclusion.
Those are excellent points, Kiana.
Hey, Stacey, really quick, this is Michelle. And to follow up on that, if anybody has any questions about available funding and grants related to that, FCC has some great grants, USDA has some great grants. There's a lot of federal grants out there to increase that broadband and to work on getting into those communities. HRSA has some grants out there too. So if anybody has any questions about that, well, happy to share that information.
Great, thank you. Well, we are past time, so I do want to just, finally thank everyone so much for your time. This has been truly amazing, and it's always so wonderful to hear what great things we're doing in our community and region. So let's continue to work together to improve health outcomes and quality of care. So thank you so much, everyone.